Thank you, Stelios, for the kind introduction. Yeah, I think it will be brief. To be honest, when I received the title of the discussion, I had doubts. I said, oh, maybe Katerina, that comes from the interstitial, she doesn't have, because my first comment was, well, do we really need to discuss it? Seriously, do we need to discuss it? But is there any doubt of the importance of eosinophils treatable trait apart from Kostikas that needs to do it as its role? So let's briefly do it, because as I said, I don't think there is much to discuss. I won't go into what a treatable trait is. Briefly, just what characterizes that it has to be related to clinical relevant outcome. It has to be identifiable and measurable, and it has to be treatable. I won't even bother to go into identifiable eosinophils, whether in blood or in sputum or whatever you want. I think we know how to identify them. Treatable. So the trait is eosinophil. The treatability, as for the title, is what is related to eosinophils, which is everything, direct or indirect, that brings eosinophils as part of the story of the pathology, of the evolution, and of course of the treatment. I think with biologic we have had really an important step forward in the knowledge of this concept, because while it's true that we know that eosinophils are related mainly to one cytokines in terms of maturation and evolution, IL-5, we'll see that themselves, in addition to release the granule, they release T2 cytokine, IL-4, IL-13, IL-5, which means that the T2 network, it's a single one. And when we break one piece of this network, we break the entire network. So the trait is eosinophils that we use for as a marker. The treatability is the type 2 inflammation. Relevance, just 2 words on the relevance. This is just to summarize the data available on the fact that the higher the blood eosinophil count, the greater the risk of exacerbation in a very large study, but broadly in a real life population. This is the Copenhagen Health Study, and it's clear, whatever the measurement, that the higher the eosinophil, the higher the risk of exacerbations. It's relevant also for outcomes that are quite important, such as mortality. It's not a trivial one. And there is it's an old data, but I think mortality worth being mentioned anytime it's possible. So high eosinophil is associated with increased risk of mortality. Not to mention prediction of response to treatment of inhaled corticosteroid, for example. This is clear. This is the IMPACT study, that in the absence of inhaled corticosteroids in green, the higher the eosinophil count on the x-axis, the higher the risk of exacerbation. This is exacerbation. The same is true again for mortality, which is not secondary outcome. In the absence of inhaled corticosteroid treatment, the higher the blood eosinophil count on the x-axis, the greater the risk of mortality on the y-axis, and the same is true for cardiovascular event, for MACE event, again related to mortality. And this is Mario Cazzola, nothing less than Mario Cazzola, putting together the data on these predictive values, eosinophils more than 300 when comparing ICS-containing medication, a triple versus LABA-LAMA, drop the NNT for exacerbation, the number needed to treat it for reduce an exacerbation, to 9 patients, as compared to 46 when the eosinophils are less than 300. So it's clear that it is a marker and that we modify a trait. Even when Kostika is involved, actually, in a study, I'm sure he will use this on the other way around, but it's clear it's clear that by increasing eosinophils from less than 150 to more than 150, the prediction of efficacy of an inhaled corticosteroid containing medication is increased. And the same is true for 300 eosinophils, less than 300, moving above 300, we have exactly the same signal. So Costa is saying the truth here. He's saying that the higher the eosinophil, the greater the trait can treat the underlying mechanism. Even more when we withdraw inhaled corticosteroid from triple therapy, the higher the eosinophils in patients that are in triple, the greater the risk of exacerbation they will encounter withdrawing the inhaled corticosteroid. Let me finish with what I said on the trait and treatability, because with biologics we have really understood much more on how this works. This is dupilumab. The trait to enter the eligibility is 300 eosinophils per microliter. So treating with dupilumab, there is no change in eosinophil. It is a trait that identifies the treatability, which is confirmed by the fact that we modify type 2 inflammation. These are changes in FeNO that are clearly modified by the treatment of dupilumab, and we know that this is associated with a reduction in the number of exacerbation. It is associated with an improvement in lung function. The previous one, I guess, is this one. So associated with an improvement in lung function, not only reduction of exacerbation, and this improvement in lung function, again, it goes with baseline eosinophils as predictor of the efficacy. It's even more clear when we use a monoclonal antibody that specifically target IL-5, so it decreases eosinophils, which is in this case mepolizumab. And in terms of exacerbation, it's a beautiful picture showing the clear evidence that the higher is the number of eosinophils at baseline, the greater is the likelihood of reduction of exacerbation, specifically in this case. So we'll go into really treating the trait, the exacerbation that are requiring inhaled corticosteroid only in red, not exacerbation that are treated with antibiotics only. So nothing to add. I think we are wasting time because it's there is no doubt and there is no uncertainty, and I think that even Kostikas is incapable of negating the evidence. And with this, I would like to thank you for the invitation.
Alberto has done a great job to convince me that he's right. So now I need my slides because I need to show the exact evidence that Alberto has not shown to all of you. But first of all, I will start with some conflicts of interest before I'm doing that. And the obvious conflicts of interest, I need to show the actual slide. Guys, you need a faster computer. It's coming. No, I need to show you, Alberto, why I'm speaking, against my heart now. And the reason for that is that, besides these conflicts of interest and everything else, so, I have been preaching in favor of blood eosinophils for more than 10 years. So whatever I say will be used against me, and just because of that, I will use legal terms. So the only thing that I need to do now, Alberto, is to create reasonable doubt, because you have shown a lot of data, and this is a legal term, and why am I using it? Because first of all, you have said that, using blood eosinophils, we can predict the future. So Canada, yes, they show that if you have high blood eosinophils, you are at higher risk of being readmitted if these are measured during an exacerbation. But if you go to Spain, higher blood eosinophils are related to lower mortality, against what you have shown, 15 years ago. I'm joking now, but we'll continue. So additionally, if you go to France, blood eosinophils are not related to exacerbations. So we have data, and also from the US, because you didn't show the spiromics data that have a list of predictors of consistent exacerbations, but not blood eosinophils there. And the additional thing is that if you go back to the UK, it's a predictor in ex-smokers. not in current smokers, of exacerbations. Last but not least, sputum eosinophils are much better than blood eosinophils, and these two things are not really related to one another very strongly. There is an association, but this is not 100%. So based on all of that, I think that you and I have driven everybody to the land of confusion, and if you see any resemblance with Phil Collins and Mike Rutherford, it could have been like that. So based on that, I will continue and I will say that, well, you showed data on the prediction of response to ICS. This is solid data. You had some data from IMPACT. You had some data from ETHOS. This is the hypothesis that Dave Singh had put together a few years ago. And as you can see down at the bottom, there is no cut point for blood eosinophils, and the strongest predictor of future exacerbations is the previous number of exacerbations. And I will argue in favor of that, on top of everything that you have shown, because you have shown, some of my data, so I need to show some of your data, so I don't see any 300 or 150 or 3% here, and this is the first analysis of the tribute study. So we are confused around the cutoffs. And the additional thing is that in the impact study, in terms of efficacy, the efficacy is different in current and ex-smokers. And the cut point of efficacy is very lower in former smokers than in current smokers. So there is a little bit of confusion still there. And this is very recent data from last month. This comes from the FLAME study. And Alexander Mattheudakis has shown in that LABA-LAMA is better than a LABA-ICS, with the exception of patients who are ex-smokers with high blood eosinophils. Here the cut point is 200. So to cut a long story short, you have argued again in favor of what I'm showing here from another post hoc analysis of FLAME, not the one that we co-authored, another one. So in this post hoc analysis, patients who will benefit from ICS are those who are treated with OCS during exacerbation. So we need to phenotype and endotype also exacerbations, not only using blood eosinophils. So to go back to the Dave Singh slide, and now this is Diana Stoltz and Mark Miravitles, in exacerbating patients, if we have very low blood eos, no ICS. If we have high blood eos, yes ICS, but majority of patients are in there. And we need to decide if they are current smokers, if they have, what type of exacerbations they have, and if they have many events. And this is the evidence by Gold that is again a little bit confusing because of the confusion, because we are using 300 and sometimes we're using 100 and again we're using 300, and this is the confusion that we have around blood eosinophils. I need to have some arguments, Alberto, I'm sorry for that. So what are people doing in real life? Are we using blood eosinophils? This is data from 5 big European countries from the Adelphi database. 40% Gold B are using ICS anyway against any evidence, but this is what they do in terms, and these are real life physicians. They take into account exacerbations, and you can see that the more the exacerbations, the more the use of ICS, but they don't take into account the more blood eosinophils, and they do the same irrespective of the level of blood eosinophils. So physicians are not using blood eosinophils. This is bad. We need to improve that. But anyway, this is an argument in my favor, so I'll use it. So, additional thing. It matters when we measure them. So this is data from the UK, and you can see that after 8 years, patients who have more than 340 blood eosinophils, this is in red, only less than 20% still have consistent eosinophilia. What is stable is the low blood eosinophils in many patients. So this is important, and this is an untreatable trait because there's nothing we can do about those. And the additional thing is that, and these are data from the PROMISE COPD study that we have done with Diana Stoltz a couple of years ago. And here, in exacerbations, blood eosinophils were lower because usually when we measure them, we have given systemic steroids to our patients, so we cannot have a good treatable trait. And the additional thing is that there is circadian rhythm. And we need to measure blood eosinophils early in the morning until lunchtime in order to have the highest possible values. So we need more than one measurement, and this is a UK publication on that, and this is our publication from the Sunset study. And in the Sunset study, we withdrew ICS from triple therapy to go to a LABA-LAMA, and the patients who were at risk were those who had consistently twice blood eosinophilia, not the ones with one measurement. So do we need two or more? So how is it a treatable trait if we need more than one? or how we are going to use it. So lessons from biologics, you have done it. You have done very well. You have shown dupilumab. Dupilumab has done the clever studies, but let's go a little bit back because there's a lot of studies here, and this is our editorial because the road is still long and winding. And I'll show you, first of all, what happened when we tried to all COPD patients to eliminate blood eosinophils. Nothing. 2 negative studies from benralizumab, and the post-hoc analysis of benralizumab showed that on top of higher blood eosinophils that you can see on the left-hand side, you need to have more exacerbations, you need to have reversibility, you need to have lower lung function, so eosinophils is not enough to show the treatable trait. And on top of that, you have shown some data, but you have not shown the whole data of MATINI. And MATINI, yes, it has reduced moderate to severe exacerbations, it has reduced severe exacerbations, but it did not improve lung function or quality of life or symptoms. And the additional thing, and this is the second study that was published in another New England journal, the New England Journal of Medicine Evidence, at the same time of MATINI, and this is the COPD HELP, and you can see that after an exacerbation, starting mepolizumab did not have any effect on exacerbations, although it reduced blood eosinophils. So it's not enough to treat that. Last but not least, I need to provide another suspect. So in order to create reasonable doubt, and this suspect is FeNO. And FeNO has all the problems that all biomarkers have, and it's affected by smoking, it's affected by ICS, etc., etc. But it is a predictor of exacerbations. It can give us a hint of whether we have a viral exacerbation. And on top of that, and this is a very recent review, it may provide more information than EOS, and you can see that it may provide information about hospitalization and mortality. So let me put everything together. We probably need to start talking about phenotyping. And these are my arguments to create the reasonable doubt. So first of all, blood eosinophils are not an ideal predictor of future risk because we have contradicting data and also of response to ICS because it's not happening in all of the patients. We need to have ex-smokers to have the best performance. The additional thing is that they have variability and they are not universally used by physicians, and we need to improve that, I agree. And elimination or even reduction does not solve all the problems. Patients may continue to exacerbate, for example. Last but not least, we have a very good alternative suspect that we may need to be using with all the problems in COPD. So we discussed arguments and we have the hype. So the hype is that blood eosinophils will solve all the problems. However, and if you know my arguments are not enough, you can see what's happening in the literature. So the previous 10 years, everything was going up, but the last 3 years, everything's going down. So we don't care that much about blood eosinophils in COPD. And these were my arguments, but I have to tell you the full truth now, Alberto. So you have spoken against my heart. You have spoken in favor of my heart. I have spoken against my heart. And this is what the great Bard has said. So I love blood eosinophils and FeNO with so much heart. Come on, I lost this one. So much of my heart that none is left to protest. So I will let you win this time, sir. But don't worry. Thank you very much.